Hello everyone and welcome to Gyan's Academy. In today's NCLEX review series, we are diving into Marfan Syndrome, a genetic connective tissue disorder that's essential for your NCLEX exam preparation. We will break it down step by step to ensure you have a solid understanding. Before we dive into Marfan syndrome, I would like to ask you to subscribe to our channel on various platforms. If you have already subscribed, a big thanks you for your support. Be sure to watch this video until the end to get valuable NCLEX practice questions on Marfan syndrome. Let's get started. Marfan syndrome is a genetic disorder that results in defective connective tissue, which can affect a person's skeleton, heart, blood vessels, eyes, and lungs. Marfan syndrome is caused by mutations in the genes called FBN1 or fibrin 1 on chromosome 15. It's an autosomal dominant, which means that even if there is a normal copy of the gene, a single mutated copy of the gene, another word, heterozygous mutation, is sufficient to cause the disease. The FBN1 genes encodes fibrillin 1 protein, one of the three fibrin subtype. In Marfan syndrome, fibrin 1 is either less abundant or it is a dysfunctional. As a result, there are fewer functioning microfibrils in the extracellular matrix, and that means there is a less tissue integrity and elasticity. Connective tissue is found throughout the body, so this can affect nearly every system of the body. Now let's look at the clinical manifestations. One of the hallmark characteristics of Marfan syndrome is the morphanoid body habitus. This means individuals tend to be exceptionally tall with the long arms, legs due to excessive growth of the long bones. Another key feature is arnectodactyly, which refers to the long, thin fingers and toes. The term arnectodactyly comes from the arachnid, the group of spiders known for their long legs. You might also see changes in the chest shape. Pectus excavatum is where the chest sinks inward, while pectus carinatum causes the chest to protrude outward. Scoliosis or a sideway curve of the spine is another common skeletal issue. Additionally, individuals may struggle with the fully extending their elbows to 180 degrees and they often have flexible joint. Facial features can include a downward slant to the eyes and a narrow plate which may crowd the teeth. In the skin, Marfan syndrome can lead to stretch marks. This marks appears due to the underlying connective tissue abnormalities. In the lungs, Marfan syndrome can cause formation of bullae. Bullae are large abnormal space that replace the normal lung tissue. These bullae can disturb normal lung function and increase the risk of pneumothorax, which is when air leaks into the space between the lungs and chest wall. In the eyes, Marfan syndrome increases the risk of retinal detachment and lens dislocation. The lens often moves upward, which can impair vision and require surgical intervention. Serious features of Marfan syndromes are cardiovascular. Over time, the aorta, the large artery that carries blood from the heart, dilates, which can lead to aortic wall insufficiency. This condition causes blood to leak back into the left ventricular during diastole. The aorta also undergoes cystic medial necrosis, where the central layer of the aortic wall degenerates. This weakness of aorta making it more prone to aneurysm, dissection, and even rupture. Marfan syndrome can also be a risk factor for mitral valve prolapse. This occurs when the mitral valve bulges into the at left atrium during systole. Not everyone with Marfan syndrome will experience all symptoms, and their severity can vary. Symptoms typically become noticeable as a child grows, although some may present at birth, known as early onset or neonatal Marfan syndrome. Diagnosing Marfan syndrome involves evaluating several key factors. A diagnosis is typically made if a person exhibits clinical features associated with a condition such as aortic diseases or dislocated lens, a relevant family history, and confirmed mutation in the FBN1 gene. While there is no cure for Marfan syndrome, treatments are available to manage its symptom. For instance, if the eye lens become dislocated, it can be surgically replaced with an artificial lens. In a case where the aorta becomes too wide, surgical repair can prevent dangerous complications like dissection or rupture. Medications also play a crucial role. Beta blockers are used to slow aortic dilatation, and when combined with the angiotensin receptor blocker, losartan, which decreases TGF beta signaling, they can further slow down the progression of the disease. To recap, Marfan syndrome is a genetic disorder caused by FBN1 gene mutation leading to weakened connective tissues and upregulated TGF beta signaling. This results in a tall, thin body type with the significant tissues in connective tissues, especially in the aorta. Thank you for joining us for this overview of Morphin syndrome. For more information or support, please visit the resources listed below. Stay informed and take care.